evening and welcome to another exciting, informative episode of Health Check on Hope TV, where you look and live. My name is Kerry Kagiri, and today we talk maternal care. All things maternal care. Remember, we are live on Facebook. What you could do is go ahead and share that link with everyone who needs to watch this, because this is important information for every part of the family. Even as we do that, our text line is open and our call line will be open shortly as well for you to interact with us. Follow us on Facebook, Hope TV Live, and across all social media platforms. In studio with me today are two amazing guests. Now, we do have Dr. Wachira Murage, who's an obstetrician-gynecologist. And I went through training to say that. Can you say it for us?
Obstetrician and gynecologist.
I think your first lesson in medical school is how to say
The terminologies.
the terminologies.
Yeah, they're quite long and very tongue-twisting, so you have to learn them.
Thank you for joining us, sir.
Thank you.
We appreciate your company. And also Esther Kimani. Now, Esther Kimani is also called Esther the doula. Yep. She is a doula and child care specialist. And she brought us a little friend in studio. So please, let's start by defining what it is a doula is, because people are like, doula?
Yes.
Yes.
So a doula is somebody who supports mothers or expectant parents in matters childbearing. So right from how to carry your pregnancy, how to prepare for labor and birth, and afterwards just the actual care of the baby, breastfeeding. So doula is a trained person who is trained to offer education, childbirth education to you as the expectant parent, and be able to offer emotional, psychological support to you.
And this runs for how long?
Right from preconception. Sometimes, you don't know how what you will need to do to give birth, to get pregnant. What do you even need? How do you prepare your body? So sometimes it can start right from before you get pregnant. But most times we engage with mothers when they're already pregnant, maybe the second trimester.
Okay.
And support. Like for me, I support up to age 2.
Age 2.
Yes.
And the obstetrician-gynecologist, there are those who have no clue.
Yes.
Could you please describe what it is exactly you do in the medical practice?
Okay, thank you. Obstetrician and gynecologist. Obstetrician means issues of delivery. Delivery, mothers, and delivering the issues of delivery, pregnant mothers, taking them through the pregnancy state, and then up to delivery. After they deliver, then there's a period, of course, postpartum period, that you take care of them. When it comes to gynecologist, then you're saying it's diseases, more specifically the reproductive health diseases, and that's what gynecologist deals with.
Is it specific to women?
Yes, it is. The only time that we talk to men is when we have fertility issues.
Okay.
So at that point, then we do involve the men.
Okay.
Other times during pregnancy, we really like the partnership between the husbands and the wives, especially during pregnancy period. Various decisions to be made. We also like them joining the doula during the delivery process, and after that to take care of them, because their issues. Pregnancy is a different situation.
Okay.
And they need a lot of support.
Yes.
The husbands and the men happen to join us
Okay.
in those times.
We are in a time of COVID-19. It's good to see your faces, because you came in, you had masks. Now, I couldn't really, now that we are in here in a very safe environment, I can now see your faces. How has COVID-19, because we cannot ignore it, how has it affected your practices?
COVID-19 has really affected the practice. There is generally a fear, so people are not coming to hospital. The pregnant mothers tend to call the hospital unless they have a very, very need to come and see the doctor. They want to call from home, and they have all sorts of questions. Doctor, will it affect my pregnancy? What's happening to hospitals? So some will go and survey the hospital. They want to see how are the hospitals, what distances is covered. Of course, the hospitals are now ready, for issues of the social distance and the hand washing and all those things are ready. So, but in terms of people coming to the clinics, they are a bit scared of coming to the clinics. But in terms of delivery and those issues, we don't have have a problem.
Okay.
And we can assure, the patient that should not fear going to the hospitals
Good.
where they need to go and have babies.
Yes, please. Doula, what are some of the things that you've gone through, especially people leaving hospital earlier, issues like those?
So with a lot of people, people are being discharged a bit faster in some hospitals. And what's happening when they go home, they're not yet quite ready. Maybe they were not showed how to breastfeed, because I had a mom who was released in 24 hours.
Wow.
So by the time she went home, she did not recognize how to breastfeed. So for us as support people, we're having to do some of this support at home. Once the mom has been discharged from hospital, we are following them up at home. We're doing a lot of, as he said, calls. Even showing sometimes how to place the baby on the breasts through Zoom,
Are you going to show us?
Yes, I will.
Is this the moment?
I will as we go along.
Okay.
Yes, so it's quite a change.
Yes.
But we are encouraging mothers to breastfeed. That it's very protective to your baby when you breastfeed.
Yes.
So it's important for you to know how to breastfeed so that you're able to nourish your baby, but also provide those immunological properties that are amazing in breast milk, and so that your baby can also be protected.
Okay, so don't leave the hospital before you're sure.
Yes.
And if you're not, look for Esther the doula. Let's talk about this pre-conception checkup. What does that include?
Thank you. This is a very important aspect of preparation for pregnancy. Unfortunately, in our country, not many people recognize the aspect of pre-conception checkups and care. Most of the people just appear when they are pregnant, and they are there. Doctor, I'm very happy, I'm pregnant. When you ask them, did you visit the doctor for any checkups before you got pregnant? No. I just got married, and here I am, and I'm pregnant. But it's very important because this is a time that you can be able to make some diagnosis of some underlying conditions, like diabetes, hypertension, thyroid disease. This is a time that you can advise if their BMI, the height to weight, their weight. This is the time you can tell the person now, you're likely to increase some weight in pregnancy.
Yes.
Would you kindly, reduce some weight, do some exercise, so that you have this kind of relationship between the height and weight as you get pregnant. There are so many other aspects, history.
Yes.
What kind of family do they come from? Are there other diseases, that we know can affect pregnancy?
Yeah.
How are their bodies? Yeah. So there are so many aspects that we like, taking care of and checking the organs before they get pregnant. And we recommend, in most cases, for them to have a single tablet of folic acid for about 3 months before they decide to get pregnant.
Okay.
Folic is an important, very simple and very inexpensive tablet that helps to prevent miscarriages. It's not 100%, but it can do close to almost 70-something% of some pregnancies that were going to be lost. And that is one of the cornerstones of the pre-pregnant state that we do, among the other many tests that we can do.
So it's physical, it's psychological,
all
round.
All round.
For you, doula, what do you do with someone pre?
So one of my trainings is in terms of nutrition.
Okay.
And we find that most of us really don't eat well. And so our bodies, we have deficiencies. We have places where sometimes you're iron deficient, or you've not even ever had of folic acid in your food. How do you make sure that you're getting enough? As you talked about the BMI, maybe you're overweight or you're underweight. So there are all these things that we look at. And so we work in consultations with Daktari so that if a mom is wanting to conceive and they have these issues, how can we make sure that they are already healthy, they're eating healthy? We know even for men, some things that we take. For us, I do the counseling for both the partner and the mom.
Yes.
And you find that some men, some habits that they do, like for example, smoking and drinking a lot. Taking foods that are high in soya, for example, will affect sperm quality. So little things like those. And so it's very personalized, and we're able to walk through how
Yeah.
do you actually prepare your body, but also emotional states. If you're going through a depressed state, you're stressed at work, maybe that's not the right time to get pregnant, because we know stress hormones in pregnancy can cause some damage to the growing baby. So things like those, just having to sit down and work through the process.
You've mentioned people might not even know what folic acid is, or many things. How did you get into being a doula? I'm very curious. You're a parent, right?
Yes, I am.
You're a mother?
I am a mother.
And
yeah.
when you were giving birth, did you have a doula?
No, not with my first baby.
Okay.
It was a very difficult time. She's a teenager now.
Wow,
and
congratulations.
Thank you. But it was a very, very, very difficult time. I didn't get to breastfeed until maybe almost when she was almost a month, because I didn't know much. And she got sick, she got admitted. I had a very difficult pregnancy. I was very deficient in some things. So my experience actually made me change my career. So instead of going back to my previous profession, I went to school.
To learn about
being, yeah.
Daktari, would you advise ladies that are watching, families, to get a doula with this process?
Yes, I would highly recommend that they get doulas. It's only that probably in the general public and this country, people have not been informed about the importance of a doula. But a doula is a companion. And you realize in most hospitals, the ratio of the patient to nurse is quite wide. And you may find a midwife with about 3-4 patients, and they're not able to give one-to-one. So when one particular laboring patient has a doula, then they are shown how to labor. And although it's painful, but it's being a very exciting moment. And that teaching, and you see the relationship has started early, and coming into the labor room. And they're told how to breathe, how to endure contraction. And the gynecologist is already waiting to receive the baby. The pediatrician is waiting. The midwife is there. So that kind of complete comfort of the patient makes the delivery process quite enjoyable.
We've talked about preconception. Let's get to now. Daktari, Kerry has come in the year 2021. Thank you, Jesus. I have come and I've said, Daktari, I'm pregnant.
Yes.
What do we do from there?
So this will be the start of the antenatal period. So you have already taken you through the preconception. We have prepared you. You are now ready. You are now with us, because now you're planning to be a mother and you're pregnant. So we want now to take you through the stages of pregnancy. And they're normally divided into 3. Normally you have the first trimester, second and third. The first trimester is about 12 to 14 weeks, so it's quite early. And we take you through what are the expectations in the first trimester. We will not fail to mention that you need good nutrition, as Esther has said. We will not need to explain to you the importance of things like doula, hospital, feeding, exercise and all that. And then what are the things you expect in the first trimester? Things like nausea, loss of appetite, laziness. We also need you to be with your husband, because sometimes some pregnant ladies can tend to be a bit anxious, and that might be mistaken, like the lady is being a bit rude or something. So we need for the family, and especially the husband, to be aware at this particular time. This is the time also we're planning to have a first ultrasound, so that we can confirm that indeed there's a pregnancy that is growing. There are various tests that are normally done. The antenatal profile test, this is the period that they are normally done. And in many cases, we want to start on supplementation. There are some supplements that are normally also needed to be taken, calcium supplements and others called multivitamins. So this is normally a preparation period. And we take through the mother, this is what you expect in this first trimester. And then the second trimester, we mention things like this when the baby is going to kick and move. So the mothers are normally very excited when they feel something kicking and they can see the bulge. So they'll be happy to show around that now they are there. And we do another ultrasound around 20 weeks. And this is the time now we want to look at are there anomalies? Are there abnormalities in
Can you
this
tell
baby?
the gender by this time?
And the gender, if you get a good ultrasound and the baby's position is right, then you can be able to tell the sex. But many times the baby is caught because the position for the baby, they bring up their legs, the hands, so they are normally kind of flexed. We call it flex position. So it's not easy sometimes to tell the sex. But we normally are able to know that this baby has a good head, the heart is beating well, the legs and the limbs are there, and it's quite comforting. And that time also, you know, it's time now to start mentioning things like now you need some Lamaze classes.
Yes.
Yeah, and you need your husband to be there.
Okay.
So that's when you look for people like Esther again. We set them there. They now start bonding and learning in preparation for that trimester, which is normally the third trimester. And during this particular time, now the mother is a little tired. You know, the weight is more, the baby is vigorous, and they are quite keen, they are anxious, and you want to do a final ultrasound. You want to check again blood sugar, which you did in the first trimester, and make sure that it is okay. You want to do another hemogram to make sure that they have enough blood in preparation. And again, this is the other time now to farm up on the hospital.
Yes.
Because this is very, very important. This you know, the economic situation is not good, so you're going to take them through that these hospitals offer this kind of plans for delivery. You know, if they want private or they want to have packages or they want a certain hospital, it's time to take them through, because this last trimester is when they are going to make a booking, so that now they can deserve a hospital. So the time of labor, when it comes, because you are preparing them, you are telling them that labor might come at 3 a.m. and you don't have your card, you'll be confused. So you need to prepare your bag. The doula has helped them to pack their bag. This is what you need. And the bag has their card. And then at the hospital, so when the labor comes, and then you take them through the process of labor. How does it come? These are the signs. When you hear this, please call me and inform me that you're heading to your hospital, so that I'm aware. And then you inform your doula that you are heading to the hospital. So all of us are ready. And when you get to the hospital, it's not a time now to open a file. You already did it.
Okay.
Yeah, there's that birth plan.
So it's straight into
into the delivery, and then the midwives take you over, and then we come in and continue.
Wow.
Yeah.
I want us to talk about Lamaze classes, because that's what he's mentioned. But question, I've always, I don't know where I saw this, but home births, is that something you'd recommend?
Home birth.
The correct answer is yes. I don't know.
I'm not too sure. We would not be very, very comfortable.
Okay.
Because sometimes, delivery does not come without some complications occasionally, like bleeding, which is the commonest. Pregnancy-induced, high blood pressure might come, and they might get a fit. Infections. So we are a bit not comfortable for home births.
Okay.
Sometimes it happens. Because like now, if in the way the situation is, someone might be delayed. The first delivery point, the first delay when they're at home and before they get to the hospital, it can happen.
Okay.
But we do not want it to be a birth plan.
Okay.
Because there can be complications which can be far-reaching.
Okay.
Yeah.
Okay, that's good. I'm still looking forward to home birth, but let's talk about Lamaze classes and this process as well for you. Someone has called you, Esther, how are you? This has happened. Esther the doula.
Yes.
What do we do?
So Lamaze classes are childbirth education classes.
Okay.
They are preparation classes that a mother-to-be with her birth partner take in preparation for birth. Now, a lot of us, studies show that when a mother is well prepared mentally and she's well informed about what her body will be going through, they actually labor better, they labor more efficiently. And birth, what most of us don't realize is that birth is pushed by hormones that come from the brain. So as we know, if the brain is not working properly and a mother is stressed, some of the hormones that are necessary to help this labor to progress will not be there. And so it's important for a mother to be well prepared, and when she is, then she relaxes in the confidence that her body can do this. And then now when labor starts, it's actually easier. Daktari here will tell you that when he has a stressed mother, he's also worried because things don't quite go the way they're supposed to do, because the mother, already some of the hormones that are supposed to be working are suppressed by the stress.
Okay.
So childbirth education are preparation classes. We go through the birth plan that Daktari is talking about. We go through the labor process. This is what will happen. I like saying, many people say labor is painful. Yes, it is. But it's one kind of pain that is a good pain.
Okay.
It is the pain that is bringing your baby to this world. So it is a different pain than the pain of breaking your hand.
True.
And so how do you cope with this pain? So we can't take away the pain, it's gonna be there, but you can cope with it. And we like to do Lamaze classes with a birth partner, a husband, it can even be your mother, your sister, but somebody that will support you. A doula. But when you do the classes with that person, then that person also is not surprised. We've had fathers fainting in labor because they had no clue. If they had attended a Lamaze class, then they know what to expect during the delivery process. And they also don't fight too much with the daktari because they're already aware of what's going on.
Okay.
So that's why we like it to be a team. I actually call it the birth team.
Birth team.
And this team is all on the same page. And we are all there to support the mother through the labor and birth process.
It does take a village.
Yes.
You're on Hope TV, where you look and live. Today's conversation is on maternal care. With us is Dr. Wachira Murage, who's an obstetrician-gynecologist, and Esther the doula, who's a doula and child care specialist. Daktari, in each semester, you've talked about the starting of supplements.
Yes.
What would you recommend in the various trimesters?
We do use the same.
Okay.
Because what we are looking at is that we are saying that because of the increased demand, the mother will need calcium supplements. So we supplement them throughout. And then you have the multivitamins, which is just an assortment of many multivitamins, magnesium and all sorts of multivitamins, because these are unique elements that the body may lack, and during pregnancy is a peculiar period when the demand is raised. So you want also to, as we equip the baby, you also want to leave the mother with something. True. So they don't deplete their stores. We also look at things like hemoglobin. We normally have what is called dilutional anemia. What that means is that the level of blood keeps on reducing because the fluid in the mother increases as the pregnancy goes along. So you have the HB reduces because it's like cells, so they reduce because there's lots of fluid. So that is called dilutional anemia. So many times we also want to give them hematinics, which are sort of supplements so that they have enough blood. So come delivery, even if they lose a bit, because all mothers are delivering babies have to lose blood. An average of about 500 in a normal delivery and up to 1 liter in cesarean section, or even more sometimes. And they need to have enough.
Okay.
So we supplement them with hematinics, just to make sure that they have optimum hemoglobin.
You've spoken about that, and I just remember there are many women who suffer from pica. What happens with that? Because even me, I see those white stones and I'm just like, let me stock up.
There are many kinds of pica. Some even crave for nyama choma.
Crave
for,
so it's not necessarily for stones.
Yes. It's a kind of, it's poorly understood, but we do think, maybe Esther can shed some light, have some knowledge on nutrition.
Yes.
But we do see patients even with anemia having craving for some certain things. But we do know that they lack some minor elements in their body that make them crave for certain things.
My doctor is saying some crave for termites.
The soil from the termites.
Yeah, from the termite hill.
They do.
Go ahead, you can add on the same.
Yeah, so it's the same thing. There's been some studies that show that it could show some deficiencies, especially in the small micronutrients that the mother has, and that can trigger pica in the woman. But what we tell mothers is they need to be safe. You can't go pick soil from the ground and eat it. You'll get many other things that you are not intending. But if your pica is for oranges, go ahead and have the oranges.
I'll start with you, and I also want Daktari to answer on the same question. Week by week, what are some of the things you look at as you're taking someone who's pregnant to the process? What are the things that you'd know this baby is growing well? And then Daktari will answer the same question.
So as I said, we work a lot. Daktari handles the medical part.
Yes.
And so usually what happens when a mom has had clinic, sometimes they have questions. Maybe there was a long queue, she was not able to ask questions. So we usually sit down with the mom, and she'd be like, oh, what did the clinic say? What did Daktari say? And usually they say, oh, the baby is growing well, or they say, my baby is measuring small to the weeks that I am in.
Okay.
So what does that mean? And sometimes that would be now having to just explain to the mother that if the doctor didn't seem too worried, or even to be able to tell her that maybe she needs to ask her doctor more questions.
Yeah.
Or sometimes maybe it's nutrition, and we're like, are you eating well? Like I had a mom this week whose baby was really small, but she's not eating.
Oh, okay.
So she's not able to eat.
Yeah.
Her appetite is very bad.
Yeah.
So it's sitting down, how can we help your appetite? How can we help you eat? Because she says she feels full, but maybe she can eat small meals through the day. So having a plan.
Okay.
So that's how, for me, we approach it.
Okay.
We support it.
There's
that
no
way.
you sit and you're like, hey, mtoto ashageuka.
Yes, we can do that because, of course, my training is part of that.
Just checking.
But usually, it's always with, and for example, I can have a mom, especially in this day of Corona.
Yes.
They don't want to go for clinic. So I saw a mom and I was like, the way I see your baby looks like they're breech, and you're almost 38 weeks. So I think you really have to go for that clinic.
Yes.
For your doctor to confirm, to do an exam and confirm.
Okay.
So I cannot confirm for her, and she was able to go, and actually her baby was breech.
Wow.
And yet she was waiting, and for a breech baby at 38, 39 weeks, it means that there needs to be somebody monitoring you.
Many people don't know. Me, I know what breech is. But there are many people who are watching who have no idea what is.
Daktari can explain what breech is.
Yes.
Yeah. Okay. Thank you. Breech is when you have the head up.
Okay.
And the behind of the baby in the pelvis.
As opposed to
the opposite.
Okay.
Because the natural position is the head should face down.
Okay.
And the behind should face up.
Okay.
That is the natural position.
Okay.
But many times, a few times, about 3% of the pregnancies are complicated by breech, which is now the head facing up and the behind facing down.
Is there something that causes this?
Breech, you can divide it into two.
Okay.
You can have complicated breech, you can have uncomplicated breech. When you're talking about complicated breech, you are saying that there's an abnormality.
Okay.
Maybe the head is big, and that's hydrocephalus, and now an abnormality. Because if you look at the shape of the uterus, it's wider on top and then narrows as you go down. So if you have an abnormal big head of the baby, it's looking for a bigger part of space of the uterus to feed. And then you can have lots of fluid. It's called polyhydramnios. Means that there's an issue with the consumption of the fluid. And the baby could have abnormalities in swallowing. So the baby keeps swimming.
Okay.
Or the lady's pelvis is small. So the baby's head cannot fit in the pelvis. So it has to look for another place to stay because it cannot fit on where it's supposed to be on the lower part. So that is complicated breech.
Okay.
Uncomplicated means that it is just breech. It just happens to be breech. Otherwise, everything is well. So that is the uncomplicated breech.
How does a mother know this baby is growing well?
Yes, thank you. We do lots of teaching, as Esther has said. That is one way that we equip the mothers, to be able to know that their babies are growing very well. But if you look at the antenatal clinic, the way it is programmed, you can have what is called focused antenatal care. So you're saying that you can see the mother about 6 times the whole pregnancy.
Okay.
But we, as gynecologists in this country, we try to see the mothers on a monthly basis.
Okay.
So we see them on a monthly basis up to around 36 weeks. Then you can see them every 2 weeks, up to around 38, and then weekly until they deliver. During these times, we explain a few things. And we are saying that when the mother comes to the clinic, we want to check vital signs. And the vital signs are temperature, the blood pressure. Blood pressure is very key for us because of the pregnancy-induced hypertension, which now seems to be now the leading maternal issue.
And how does that work? If you could just explain it just a bit.
The preeclampsia.
Yes.
The preeclampsia is pregnancy-induced hypertension. It's normally seen from 20 weeks onwards.
Okay.
Yeah, it is probably understood in terms of its cause. We only talk about risk factors.
Okay.
So you're saying if the mother has twins, if the mother has previous blood pressure, the mother has other comorbidities like diabetes,
okay,
then there's that situation which is normally specific to pregnancy, that the pressure goes up. And it can be defined by the pressure going up for more than 140/90, and the urine, they have proteins, because it's a multi-organ problem.
Okay.
And as much as it's pressure, it's a multi-organ. It can affect virtually all the organs, the eyes, the brain, the heart, the kidneys, and the liver. And affecting those organs, then it means that it's severe when it gets those organs. And then, of course, the generalized body swelling. Changes are coming, studies are being done, so you may find some view variations, but basically that is what is preeclampsia.
Okay.
So the mother, we talk to them and we look at the blood pressure. We look also at the weight gain.
Okay.
A mother not gaining weight, there is a problem. And it could also mean the baby is not growing, because we want them to grow about 500 grams per week, or sort of to about 2 kgs. Yeah, so we look at them. And then we look at how many weeks are they supposed to be on paper. 20 weeks? So when we put them on the couch to examine, then there's a way we check.
Okay.
Yeah, to ensure that there is a correlation between what is on paper and what we get. And in simple terms, if it's just at the pelvic bone, that's about 3 months. If it is between the navel and the pelvic bone, that's about 4 months, 16 weeks. The navel is 20 weeks.
Okay.
Then every finger is about 2 weeks until it gets over here.
That's so interesting.
Yeah,
Yes. So we are able to tell if the growth is not okay. So we already explained to the mother that if you're not increasing in weight, you're rather losing. If you don't see your bulge, increasing as days go by, then there's an issue. Yes, and then they come over, then you're able to measure and see. Sometimes you can use a tape measure as well. It's also an acceptable, way of assessing the growth. And then, of course, you have the ultrasound. Yes. And then from 20 weeks, we now start teaching them the movements, the activity of the baby.
Okay.
Yeah, baby, I'm sure Esther will give us more. We'll kick in about 10 kicks in 12 hours. So so we want to tell them, make sure, because we take the mother's word very seriously, let alone like in 3rd trimester, when they come and tell us, hey, doctor, the movements of the baby, I'm not happy. We take it very, very seriously. So that's why we want to educate them early, together with Esther and the team, that they get used to the movements, the activity of their baby. Because different babies, the first pregnancy might be different from the other pregnancy. But when they get used to the movements of the baby, then that helps when it comes to this reduction of movement. So those simple things help us monitor the baby. It might not be possible to do week by week, but it is definitely monthly to be able to tell if there's a growth. And within the month, if they follow those instructions, they'll be able to to get if there is an issue.
Some ladies don't know they are pregnant until a couple of months in. How is that even possible? Let's start with you. Just you can comment on the same and then to Dr. Because then now you have to start measuring. You're like, so you might be 3.
Yeah. So we find that common in women who don't have regular periods, so that when they miss their periods, they don't think that there's anything different. We also find it very common in people who are overweight, because you see, if you're slim and your stomach starts to grow, you wonder what's going on. So people who are also overweight might not also be able to know that they are pregnant. We also find it in, I keep telling moms who have just given birth. When they give birth, most of them will not look for a family planning method, because they think that when I'm breastfeeding, I am safe, I am okay, I've just given birth, I can't possibly get pregnant. So we find that some of these women, they discover they're pregnant because they didn't think they could possibly be pregnant again. So those are, I think for me, in
Those are the ones
in my
you've
practice,
observed.
those I have observed quite a bit. Yeah.
Doctor, you do anything on that?
Yes. As she says, sometimes is denial. Yeah, it's denial. They just, I can't be pregnant, and yet they're increasing in weight. They have a bulge, and especially the teenagers.
Yes.
There are quite a number of teenagers who, even by the time they have delivered and the baby is crying, they are still saying no, I am not pregnant. I cannot be pregnant. But as she says, that way, even also some obese mothers sometimes, it may be a little difficult to be able to, for them to say they are pregnant. But most of the time is denial.
Okay.
Yeah.
Okay. We are having conversations on maternal care. And there was a question I wanted to ask, just for our friends. Why do they call it morning sickness? And it happens all through the day. Anyway, we'll answer that when we come back. This is Health Check. It's on Hope TV, where you look and live. We're going on a short break. When we come back, we'll be talking about those dangerous symptoms that you must be able to look out for. We'll also be learning, because we have a baby in studio and all the baby needs, learning a little bit on this show. With us is Dr. Wachira Murage, obstetrician-gynaecologist, and Esther the doula, who's a doula and a child care specialist. We'll be back.
Since late last year, the coronavirus COVID-19 has emerged as a serious healthcare threat. This is an infection that has gone global and no one has been spared. The government, through the Ministry of Health, has put in measures to keep Kenyans safe against COVID-19, which is currently rampant around the world, with new confirmed infections and death cases daily. Such sanitization and screening of visitors at this border post and across every entry point in the country is very vital in preventing the spread of the disease in the country.
I'm very happy about the screenings that are going on in Tanzania and Kenya. I think it's very proactive that you're thinking about stopping it at the border so that it does not spread.
It is scary that a single cough here can lead to an outbreak of epic proportions. In order to prevent that, the government has instituted measures to keep Kenyans safe.
The facility has all the equipments you need, from handling a basic patient up to ICU setting.
However, you also have a role to play in preventing spread of infections.
Citizen responsibility is the key to the success of this initiative and these measures. Let's all do what we have to do individually. And this is how we are going to defeat this disease.
It's just our general hygiene, okay? And that now means at workplaces, we should ensure that our work surfaces are clean.
Always ensure that nimefanya proper sanitation ya mikono. Every time na board matatu, lazima ni sanitize mikono.
We have faced many severe challenges as a nation, and we have always found a way to rise above them. COVID-19 is no different, and we will overcome the pandemic. Stop coronavirus. Follow all directives from the Ministry of Health. Wash your hands properly.
And welcome back. Thank you for watching from all over the country. Keep interacting with us on Facebook at Hope TV Kenya, on Twitter and on Instagram, same account. Check us out and comment right there. We're waiting also for your questions on 22232. That's the text line right below here. And you can also call us. Our call lines are officially open as we talk about maternal care. We're talking about preconception. It's important to see the doctor before you start trying. Yes, I don't know what to use, but yes, and during and what happens. With us in studio is Dr. Wachira Murage. He is an obstetrician-gynecologist, and Esther the doula, who's a doula and childcare specialist. Even as we continue, we said when we come back, we'll be talking about those things that you cannot ignore during your pregnancy. I know sometimes for a first pregnancy, people are touchy, Simski, but what are those things that are 911 type of emergencies?
There are quite a number. For example, if you have very, very severe headaches and associated with generalized body swelling, that could be high blood pressure. And that one you cannot ignore, especially from the 20 weeks of pregnancy.
Okay.
Most ladies start to say, oh, it's part of my pregnancy, you have to swell a bit, you have to increase in weight. But if you find that you have severe headaches, and to the point that you have blood vision, yes, and generalized body swelling, then you must be able to call us, do a blood pressure, let's check a urine, and be able to be happy. If there's bleeding is a no-no in pregnancy.
So spotting and bleeding.
Spotting and bleeding, any
okay.
is a no-no
Okay.
in pregnancy. We do not take it for granted, because that would mean either some miscarriage, it would mean either the placenta has come down, so you might lose your baby. If you have labor pains, contractions coming on and off, then it is something that we may be able to we need to be informed so that we can be able to look at it. So those three are quite important.
Okay.
If you have drainage, you put a pad, it gets soaked very quickly, or you find your discharge is a bit profuse more than usual. You may not feel a pad, but you find you're feeling wet more than usual. It could be that membranes have ruptured and you're draining, and that can cause infection into the uterus where the baby is, and get a very, very severe infection, and even lose a baby. So those are very important things to
look at.
Yeah.
Esther, do you want to add anything?
Sometimes some moms will say that they feel very thirsty, extreme thirst, that they cannot be able to they take everything, but they're still very thirsty. Sometimes those could be subtle signs of diabetes or the sugar levels being very high. Again, getting checked. You are the expert of your baby. If the movements of your babies change, then, and for us, when we're teaching, sometimes, because for a long time we kept talking about when there's no movement, but sometimes also too much movement can also signal a problem.
Okay.
It would be good to go to the doctor to have it checked out. Some babies whose cord maybe has gone around their neck can be too active, extremely active. So you are the expert. So if you as a mom feel that the way this baby is moving has changed, it is very, very good to get it checked.
Okay.
And then again, if you are one thing that you see, Dr. said, we really listen to the mother.
Yes.
Sometimes it's nothing distinct, but the mother just feels like there's something wrong.
The instinct.
We call it inner wisdom.
Every
pregnant woman has an inner wisdom regarding her baby.
Yeah.
And we listen. We listen. So if she just keeps saying, I think there's something wrong, I can't place my finger on it. And some dads have told me, and I told her, don't, where are we going for what?
But she knew.
But there was actually something wrong.
Okay, we have a
yes.
a call from Catherine in Nairobi. Good evening, Catherine.
Hello, how are you?
I am well. How are you?
I'm okay.
Go ahead. Who is your question addressed to?
Okay, I have a question for the doctor.
Sure.
Okay, I'm 40 years old.
40 years old.
Yes. And my husband is 68 years old. And we have one baby. He's 14 years now. And he's been trying for a second child. So I'm just wondering, is there hope for us for a second child?
Yes, thank you for that question.
Thank you for calling.
You are 40 years old, and the husband was 68.
Yes.
Yes, there is hope. We realize that she is 40 years, and we always say maybe after 35 years, there are some changes in the ladies, especially the quality of the eggs that might affect fertility. But still, 40 years, she can be able to have a baby. All she needs to do is to see her gynae, let her do the assessments. And normally what will happen is that we want to check the organs first. Is her tubes okay? For the man, is his pumps okay? all right? After those 2, if they are normal, then you have a chance of inducing ovulation, trying to enhance the fertility. If we do enhance fertility for about 6 cycles for her, because she's 40 years, so she's, the years are going on her part. Then,
and what are cycles for those who don't?
For cycles is that we say that, yes, your periods come, then you give you medication, you try. So if you get the next periods, that's a cycle.
Okay.
Yeah.
Good.
So you have failed. So you start another cycle of the same kind of arrangement. 40 years, you may not have the benefit of time, because by maybe 45, even some early signs of menopause may creep in what we call perimenopause signs.
Okay.
So we don't have a time. So normally we advocate, and we would advocate for her IVF, in vitro fertilization, because that one has a better chance than trying. Because if you try for a long time and the age catches up with you, then it's going to be a little difficult. In fact, more than 40 years these days, IVF, we are recommending for donor eggs. Because you're already saying the eggs are not very good for IVF. So I would request that you have your checkups, and then after that, then you can try the ovulation induction and IVF shortly. It doesn't work.
Catherine, all will be well. We're looking forward to that testimony, and make sure you tell us when it happens. We are asking, bleeding first trimester and then it stops.
Yes.
What is that about?
That is threatened abortion. The first trimester, if it starts and stops, there's this question that normally comes, that doctor, I bled in my first trimester, and now I'm continuing. Will I have a normal baby? And the answer is yes. Yes, it's all or nothing theory. You either bleed and lose the pregnancy totally. If you bleed and the pregnancy continues, it's going to be a normal baby. Yes, it's just threatened abortion. Yes.
Question on this issue of rhesus factor.
Yes.
It's a big question, and you could explain also what is rhesus to us.
Okay, rhesus factor is something that it's normally a thorn in the flesh, and many ladies and men would want to know about it. But what you're saying is that we only have lots of interest if the mother is rhesus negative, either B negative, A negative, AB negative, O negative, and the husband is positive. That's the only scenario that we look at, the rhesus factor issue. And what are we saying? Is that if the mother is rhesus negative, and they happen to have a baby with a man who is rhesus positive, and they carry a baby that is rhesus positive, yes, the mother will view that baby as a foreigner. Just to use simple words for the sake of understanding. Like
a foreign body.
Yes, not part of them. So they produce antibodies. Normally, it's not that EDEX pregnancy that is normally affected. That one may come out well and there are no issues. But come the next pregnancy, and the same scenario repeats itself, then it means that they will start to be fought right from conception. Yeah, and what happens is that where the rhesus factor is placed is on the red blood cells. And if the mother fights the red blood cells, it means it's like bleeding. You're now finishing the red blood cells. So the mother will become anemic. They'll have low blood. Then because of that, then they'll have heart issues, heart failure. They'll retain, like if you see a big person with heart failure, they normally have accumulated a lot of water. In the tummy, they normally are swollen. And that is how the baby is going to look like. And then there's damage generally in the baby. And that baby normally will either die in the womb, or if they reach, they come out to be like a frog-like. They're just, something really abnormal. So that is the tragedy. However, God has made it well that it's a very rare occurrence, the rhesus isoimmunization.
Because you can't ask every person you're about to marry, what's your rhesus?
Yes, you can't. Yes, you can't. Most of the mothers are what we call non-responders. They don't respond to that challenge. Even if they are that way, they don't respond. And then, of course, now the technology has brought issues of anti-D that you normally give. So what you do is that you do a test called ICT. You want to check whether the two bloods have mixed, and if they have not mixed, then you can give that injection at 28 weeks. And then after birth, You cannot do the baby blood group, and if it's negative like the mother, you don't give any more anti-D injection. But if they're positive, then you can give. That normally will keep the mother safe for the next pregnancy.
So is this also what you do in preconception?
Yes, it's part of it.
Let's talk about a little bit more about Lamaze classes. Are there special Lamaze classes for people with hypertension, people with diabetes, HIV?
The classes are the same because labor process is the same. But what we usually highlight is that because these are high-risk mothers, they are already high risk because of the conditions that they're going through, their birth plans can change. So like, for example, if you have diabetes and your baby starts becoming very big, because mothers with gestational diabetes can have very, very big babies, or you start showing preeclampsia signs where the pressure is uncontrollable. Sometimes daktari will decide to have the baby come earlier than induce or have a C-section depending on the level. So we usually highlight and say that yes, you might need to have a different plan, or your plans can change. HIV, again, there's management for HIV so that you do not pass the virus to the baby, both with during labor and breastfeeding. So yes, HIV positive mothers can breastfeed, but there's a protocol and a guidance to be followed. So they shouldn't just decide to breastfeed. There's a way that we're able to counsel them and give them information so that they can be safe.
Okay.
Yes.
Awesome. Can we go to some questions now?
Yes.
Questions are coming in on 22232. That's 22232. And one is asking, what is your take to natural supplementation versus pharmaceutical supplementation in terms of assimilation in the body?
I know, Esther, you'll comment more in being the side of nutrition, but there's basically no much change. We recommend most of the time that they can have the natural foodstuffs, but it's very hard probably to balance the diet to make sure that they can accommodate all those needs for the supplementation. That's why now the other supplementations come in. But we really emphasize on balanced diet, the vegetables, the fruits, and taking water and things like exercises. But we know that we are not able to measure in terms of the foods that people take in the house to be able to have the natural supplements, the natural supplementation they need. That's how the pharmaceutical supplementations come in. But having said that, very, very important to have a balanced diet.
Another question, when should Lamaze classes start?
So most classes would start at around 28 weeks.
28 weeks.
Yes, because now it's Lamaze classes are supposed to be preparing you for labor and delivery and the postpartum period. Yes.
Let's go into delivery. We're here. We're ready. But we're still receiving your questions. You can call us live in studio. We have Daktari here and we have a doula. So they're ready to answer all these questions. What role do you play as a doula during birth, delivery?
Yeah. So, as I said before, we support mothers physically and emotionally and with information. We're physically there. So as a doula, I'm trained in ways to help the process of labor so that the mother can have comfort measures, what you call comfort measures.
What are those? Give us some.
These are comfort measures. So for example, if you labor when you're lying down, which most of us, when we're in pain, our instinct is to lie down and curl up, But what happens? Where is the baby going? The baby is going down. Remember, Daktari said the head is facing down. So if you lie down, gravity is not going to work for you. So we are trained in ways to help this baby engage better, travel down the journey that they need to do. We call the baby the passenger. This passenger, we need to help this passenger get to where they are going. Comfort measures are things like helping the mother, like for example, breathe. Breathing is very important. Oxygen is a natural painkiller.
Yes.
If you don't breathe, you are not going to cope well with labor.
Please explain how you don't breathe. In terms of, like, what do you mean by breathe?
When we are in pain, and on what most people, we keep saying Hollywood lied. Most people think that labor is one long pain, and then baby comes. But labor does not come like that. Labor pain is intermittent. It means it comes for a period of a few seconds, 30 to 45 seconds long, sometimes longer or shorter, and then it goes away, and mommy's like this.
This is the time you're counting contractions.
Yes, that's what we say.
I've Googled a bit.
Yes, so labor pain. But usually what happens during the contraction, the uterus is actually contracting. And what it's doing, that contraction is what's helping the baby move down to where they need to go. So when you're in pain, most of us hold our breath. That's another instinct. When you're in pain, you tend to, you hold your breath. That's why we say people don't breathe.
Okay.
So when you hold your breath, it means that also the baby in the uterus is not getting enough oxygen.
Oh, no.
And then your brain is also not getting enough oxygen. So you will actually feel more pain.
Oh, no.
And then your baby starts getting tired because you're not giving them oxygen. So breathing in during the contraction, number one, helps you cope with the pain. It helps feed your baby with enough oxygen so that your baby is able to cope also with the contractions. But also, it helps you something to focus on. Remember when you have a pain and you're focusing, like when you're running a marathon, and I kept saying labor is a marathon. So when you're running a marathon, it's hard work. And sometimes you feel like you want to give up, but you keep looking at the end line. So breathing helps you to have something to concentrate on. So you're concentrating more on the breathing, and you kind of
So that's what you're doing.
Yes, so I'm helping you do that.
I want to know exactly. So we want to see this and visualize it nicely. So that's what she's doing. She's like, breathe, Kerry.
Yes.
Doctor, what are you doing at this point?
I'm just waiting.
Oh, you know
So I'm ready. My tray is ready. The towels, the pediatrician is also ready. The baby nurse is ready.
Yes.
So those are the things that we're encouraging, because you remember there's normally a process.
Yeah.
The baby there's a descent. That's what she's working on.
Yeah.
There is the birth canal that she's trying to encourage the mother, so that in some positions it kind of opens. Yeah.
Can we rewind just a bit?
Yes.
What is labor? I had some leakage.
Yes.
What is labor and what is that process? And then now we'll put the card before the horse, sorry.
Yes. As she says, labor is a series of events.
Yes.
It is not just a one-off.
Okay.
And it's a series of events where you have pain. And this pain has some characteristic. It's recurrent, increases in intensity, and the duration reduces as we go on. It has some stages. The baby is up, and then you have the pelvis, okay? So it has to descend. Okay? Then it descends, I think it returns. That's how you remind me. And then it returns. Then it returns, then there is hitting the floor, and then there is restitution. And the baby will come out, okay? And then after that, we will hold the baby and allow the baby to turn again, and then come out.
That's what they say in the
so
movie.
it's
I
a
can
series
see the head.
of events. Yes, it's crowning. So it's a series of events. Yeah, so that is the whole process of labor.
Okay.
So what she's saying is that she's encouraging the mother to breathe in and out. But during a contraction, they hold the breath, and then they push. And we normally equate that one with like pooping. Yes, because the head of the baby is pressing on the rectum.
Okay.
So that feel is what we normally tell them to do. Please do like you're pooping.
Yeah.
And they do that.
So this is during a contraction.
During a contraction.
Okay.
During a contraction, we tell them, hold your breath. When the contraction goes, then she comes in. And they demonstrate. They are like instructors.
Okay.
Yeah, so
like a coach.
Okay.
Breathe in and out.
Yeah.
They open their mouth. That they give now the baby more
Oxygen.
more oxygen. And they also are better aerated in terms of oxygen to be able to prepare. When the contraction peaks again, they do the same. Yes.
Okay, so that's the process of the labor.
Yes.
What have you experienced during this time? She said that there's a place where the baby gets tired.
Yes.
What happens?
There are many aspects, and she mentioned some of them, like cord around the neck. Yeah, and if there's a delay, if you have poor progress in labor, because there's a process. You normally saying you have first stage of labor, then you have second stage of labor. She should be about 30 minutes.
Okay.
If it goes beyond 30 minutes, then you are thinking, is there a problem? Yes. It's during this process that the baby can get tired if there's prolonged labor. Remember, the baby is also getting tired in this process because there are contractions. The uterus is contracting to push the baby tired. So the baby is also getting tired. So if it stays more than the time that is expected, then it starts to get tired. If the cord is compressed at one point, or if the cord is around the neck, then the baby is not able to get enough oxygen. Yeah, despite the mother breathing, the oxygen is not going the way it should be into the baby you'll get tired. If the baby is in a different position, because the baby is supposed to come with this tip part of the head facing down, all right, so that it opens the cervix and then it comes out.
Okay.
If the position is different, then it means that the baby's head is giving more diameters to the outlet, and that also delays labor. And the baby, the uterus is contracting, trying to push the baby, but the baby is obstructed, and that gets the baby quite tired.
Wow.
Yeah.
This is a whole process. How do you prepare someone for, I mean, not say the worst, but for eventualities?
So we do talk about that in
Okay.
the Lamas class. We talk about, we call them unexpected outcomes. You know, things can happen, and that's why Daktari here was saying it's good to be in a hospital. You don't know what's going to happen. So, but we do talk about what are the common, we cannot cover all of them, but we do go through the common complications that can come in during labor. For example, the cord, so the baby is not coping very well with labor. Mom can start bleeding out of nowhere, bleeding right even before the labor has progressed. When the water breaks, right at the beginning, maybe
I really want to talk about this water
this
breaking.
water breaking.
Is it, you know, reality versus Hollywood?
So water, actually not very many people have their water break. Just
Okay.
around 20% of the population will have the
20.
water break before labor.
Okay.
Most times the water will break as the labor progresses on, and sometimes even Daktari has to help
Has
the
to do
water
it.
to
And that's
to break.
painful, apparently.
Again, that's what Lamas teaches you.
Okay.
It's not painful. It's painful because the mom is holding her breath.
Okay.
And so she's tensed up, everything. So breathing is amazing. It does. If she breathes in, then she relaxes and all the muscles relax. And then even getting checked and the water being, whatever Daktari needs to do becomes very easy. Yes, so the water can break, and usually it can break either like a gush, like a lot, or it can start leaking. And so you go, as you said, you're feeling like you're wet. And I usually tell moms, because they'll call me and say, I think I've peed on myself. And I'm usually like, can you smell it?
No.
Is it smelling like pee? They're like, no. Then I'm like, I suspect it's your amniotic fluid. So you need to
Okay.
go get checked.
Wow.
It's always important, anytime the water breaks, please go to hospital. Don't stay home because of risks of infections.
Okay.
So you can be staying home and you're saying, I'm waiting for labor now, I'm waiting for pain.
Okay.
But again, when the water breaks, also your baby was swimming in a pool of water. So if it breaks, the cord could have gotten displaced by the water breaking, so it's not in the right position. I use very simple terms.
Yes.
I'm not going to use the medical terms.
Yes.
So it's important to go to hospital to make sure that the baby is okay.
Okay.
Yeah, so there are different reasons why. So if a mom, for example, had hoped for a normal delivery but gets a C-section.
And that's where we are
Yes.
coming to. In fact,
Yes.
you have,
I have just
you're
got-
hired.
Yes.
When does one decide?
Yeah.
Yes.
Is it a choice you make, or is it a recommendation from the doctor?
Yes.
C-section. And also this terminology is saying alikuja normal, ama natural. I need to, let's explain all those.
Now, for us in the health profession, and I'm sure even Esther in the whole team, normal delivery is the best.
Okay.
Unless
And what is normal delivery?
normal delivery is where you go to first stage, you labor, then you go to second stage, the cervix is fully open. Third stage, the baby comes out at second stage, and that stage, the expulsion of the
Okay.
of the placenta. So that is normal labor.
Okay.
It's called SVD, spontaneous vertex delivery, just to be a bit for people to, because they hear
SPD
us.
what?
Yes,
SVD.
SVD, spontaneous vertex
Okay.
delivery.
Okay.
Delivering the head and the baby.
Okay.
That is normal, and that is what we do expect. However, there are other eventualities that come in, and most of them are during labor.
Okay.
As she has mentioned, cord accidents, the baby gets tired, the fetus starts to misbehave, there's bleeding, there's prolonged labor, the baby is bigger, the position is not right. Yes, all those things can lead us have a cesarean section.
So you're always on standby to do a cesarean section?
We are always on standby. And that
Okay.
is the other thing that now, firms up the issue of against home delivery.
Okay.
Yes, because you do want to, when you need a cesarean section, we want to have it as quickly as possible, because
Okay.
you're saying it's an emergency. The other chances you have an elective cesarean section. It's a planned cesarean section. Maybe the mom had a cesarean section before, they are not able to have a trial of labor or the scar, and therefore you plan them for an elective cesarean section. The baby is big, maybe they have twins, the position like the breech we talked earlier on, all those are indications and many others of an elective cesarean section.
Okay.
However, let me say this, there's so many ladies coming these days saying that we want to have a cesarean section.
Yes.
You know, and that one is called a primary elective cesarean section. They are asking for their own reasons. And we can tell you that we discourage. Yes. However, we do listen, because it's also a mode, and we now know that the cesarean section has come a long way.
Yes.
And now it's quite safe. It's not the way they used to be those many other days. They would stay in hospital for 7 days. You know, they would have those stitches that have to be removed. You know, the cut would be, you know, from up here to down. Now you have, you know, more cosmetic cuts. So if a lady really wants a cesarean section, and that is what they are choosing, yeah, we now know, generally now it's accepted as a mode of delivery. But by and large, normal delivery is the best. It has few complications. It's good. And when it goes, the mother feels okay, they're able to breastfeed, and you know, there's no scar to heal.
Yeah.
And they're even able to have another normal delivery, which is easier in the subsequent pregnancies.
Question coming in on our Facebook, but first let's pick the call from Mombasa. Good evening.
Good evening, madam.
How are you, sir?
Fine, madam.
Go ahead and ask your question.
Okay, I want to ask you a question.
Yes.
I've got 5 kids. And most of my kids, they were not born in the hospital. They were born at home. And I realized that my wife, yeye hana ile pumzi ya kusukuma watoto, huwa anatumia tu nguvu yani. Sasa I don't know what is the problem, kwa sababu nyinyi madaktari mnajua.
Okay. Thank you, sir.
Okay.
I think that was more of a compliment to his wife. Go ahead. I don't know. Would you like to comment on his?
He's quite blessed, 5, and normal deliveries at home.
Yeah.
So he's saying the mother is not able to push.
Yeah.
Yeah. Their mothers will take a little longer. You know, they get tired, what is called maternal distress. And possibly those are the mothers when in the hospital you're able to augment. Yeah. But I think it is okay, because
she has safely delivered 5.
Yeah.
So she was still able to do it.
You're still able to deliver. I think that is fine.
Okay. Question here. We usually hear or see women giving birth on their backs, and are told it can cause back pain and make labor difficult. Are there other positions that help to ease the process?
Yes. And for most times, that's why now we work with Daktari. So usually we would get the mom, because she's feeling the pain, and the baby is talking to her as she's coming out. So the back, sometimes semi-seated is better than flat out on the back, because the baby has to navigate that, you know, that little tailbone. You know, we have a tailbone.
Yes.
The baby has to navigate that tailbone. So to help this mother get a bit better, sometimes semi-seated. If a mama has been pushing for long and she's not being able to, sometimes side lying. So she lies on one side and we support one leg up. We've not quite gotten to a place where we squat, but we are getting there slowly, squatting. But usually, for most times, it's the back because we're in hospital, but we usually encourage that do a semi-seated so that gravity can also help you rather than flat out on the back.
Okay, one more call on our call line. Hello, good evening.
Good evening to you.
Yes, how are you? Where are you calling us from?
Okay, I have a question to the doctor.
Okay, sure, go ahead.
I wanted to confirm whether if someone had a postpartum hemorrhage in the first delivery, is that person able to be advised to deliver normally?
Okay.
On the second?
Thank you.
Yes, thank you for that question. Postpartum hemorrhage can recur. And that is very, very important for us to know. There are so many causes of postpartum delivery, like the uterus may be soft, maybe the placenta may be retained, but largely a postpartum hemorrhage can recur. And it is important that in the subsequent deliveries, they must be near a hospital where transfusion can be administered. And they should be able to deliver normally.
Okay.
They must not have a cesarean section.
Okay.
Yes.
So there is hope in that. More calls on our call line. You can call us live. You can text us on 22232. That's where we're at. Call in live and ask all your questions. Right here, we're talking about maternal care. And we were at the stage where we were in the delivery process. I have an example of a friend who was not in labor, then was in labor, and went to the hospital, and the baby was on the way. So she's just like, just give birth here. I can feel my child is... that's why I think she's talking about having the child, the mother instinct. What do you call it? Wisdom.
Wisdom, inner wisdom.
What are some of the advice you can give right now to women? Because right now you might have to wait longer than the usual. You don't have the time right now to go through the entire process. Or maybe you've gone through it and you're able to leave the house because of the curfew, one reason or another. What would you advise?
What maybe first a comments I would say is that it is important for the mothers to understand the signs of labor.
Okay.
Yes?
Yes.
So that they know. And they're basically like three. You know, the recurrent cramping pains.
Okay.
Okay, they come and go. And how differentiate between forced labor and true labor is that the true ones will keep coming.
They'll be
Every so
consistent.
10, 15 minutes or 20, they must come. Forced labor, it can come now, can come in the evening, can come after 4 hours. It's irregular. But this one's a sort of regular, recurrent contractions. If you find some discharge, the red discharge which is mucoid, or some slight bleeding, or the drainage that you mentioned earlier, if you get such signs, or even a cramping sort of, then you do not ignore. And especially if you have delivered before, as soon as you get those early signs, try to navigate your way to the hospital. Because you might wait and you might get what is called fast labor. And then before you get to the hospital, you're in casualty, you're screaming and you're pushing. So as soon as you get those early signs, it is important to make your way to the hospital.
Okay, let's talk about, oh, you need to comment?
Let me comment.
Sure.
Especially the people who give birth quickly. Most times it's because you are equating contractions with pain.
Yes.
Now, contractions is you will feel a tightening in your tummy that is, it's almost like somebody is really holding and squeezing your tummy and it relaxes. So for some people who have very, pain levels are different.
True.
So some people with very high pain tolerance may be feeling the squeezing, but they think, oh, I'm waiting for the pain that everyone talks about. So if you find that squeezing, that tightening and relaxing is coming in a regular fashion, especially in this time of corona, please pay attention, because they could be contractions, especially if you see, as you said, every 10 minutes it's tightening. With or without pain, it's good to get checked.
Okay, Otieno from Nairobi, good evening.
Good evening to you. How are you?
Fine, thank you, sir. What question do you have and to whom?
Okay, this is an instance where during the delivery, the baby said it's already being seen, and the mother now fails to get the push. So what really causes that? That's one.
Okay.
Did I hear your question, Otieno?
Yes, so the next question, I'm relating to the doctor.
Yes.
Otieno, kindly, just
I think
Otieno.
I got it. She was saying
Yes.
when a mother is already fully dilated,
Yes.
but she's not feeling the urge to push
Okay.
anymore.
Is that it, Otieno?
Is that it?
Yes, so
Can you reduce the volume on your TV, please, so that we can hear you clearly? Kindly reduce the volume on your TV.
hello, the volume is now reduced.
Thank you, sir.
Okay.
Okay.
Now directing to the doctor, that is Dr. Wachira.
Thank you.
Wachira.
Yes.
Yes, okay, you offer ANC clinics. So I need to know the charges and all the way through to the delivery point.
Oh, okay. Okay.
Yes.
Thank you so much.
What's the charges?
Yes, and your clinic. How can he partner with you?
Okay. Yeah, it's okay. You are most welcome. My number is 0722764545. in a clinic called Savannah Healthcare, Kenyatta Avenue, and Upper Hill, Mara Road.
Okay, that's good. So you can talk and collaborate on that. And on his question?
He said the mother is fully dilated and not able to push. Sometimes it's maternal fatigue.
Okay.
They are tired. There's delayed fast stage. They have been laboring the whole night. They are dehydrated. They are tired. They have been told to push, and maybe, you know, the baby could be big. So most of the time, if it's fully dilated, the head has come down, we do assist them with vacuum extraction.
Vacuum extraction.
Vacuum
I
extraction.
had that stopped in 1990, but we'll talk about
Still
that.
there.
Okay,
Still
good.
there. Yes.
From Kisumu, Victor.
Hello?
Frederick from Kisumu, good evening.
Mimi Frederick from Kisumu.
Yes, sir. Karibu sana.
Kuna swali.
Okay.
Frederick.
Yes, go ahead, Frederick.
Mko mzima?
Kabisa. Salimika.
Yes, tuko sawa. Asante, Frederick.
Swali lako? Oh, okay. He was just greeting us. Thank you. Hi. You can also call to greet us. But it's interesting that the gentlemen are the ones with more questions.
Yes.
Ladies, good evening. How are you?
True.
Adan from Nakuru. Let's go to Adan from Nakuru. Good evening, Adan.
Mzuri sana, habari ya leo?
Mzuri sana, hujambo?
Salama sana.
Swali lako tafadhali.
Swali yangu nilikuwa nauliza. Niko na bibi. Nimekaa naye almost 4 years.
4 years.
Na mpaka saa hizi hatukupata watoto. Sasa nilikuwa nauliza daktari kama anaweza shughulikia kitu kama hiyo, kama anaelewa. Tumeenda hospitali mingi, tumepatiwa results, madawa mingi na tutapata.
Do you have a follow-up question to him?
Uko na miaka ngapi, Adan?
Mimi nimezaliwa 1986 December.
86.
Yes.
Na bibi yako?
Yeye amezaliwa 1992.
1992.
91.
Okay, na hajawahi shika mimba wakati wowote?
Bado.
Okay. Na mmeenda hospitali, mumepimwa vitu kama HSG, na wewe umepimwa?
Mimi nimepimwa. Mimi niambiwa kwanza mimi niko sawa, yeye ndio aliambiwa sisi yako na.
Akona?
Wanasema mara ako na infection. Mara wanasema moja ni mbaya, wamepatia dawa kadhaa. Nimeenda hospitali mingi sana.
Okay.
Sasa nioneshekana shida ni tubes,
Wanasema ni moja.
Ni moja.
Okay.
Huenda ikakuwa hata hiyo ingine inaweza kuwa na shida. Kwa hivyo ni vizuri angefanyiwa test inaitwa laparoscopy. Laparoscopy would be good for you.
Yeah.
Alafu msikae sana, unaweza jaribu IVF.
Okay, let's pause. You'll continue with that answer. But hello, good evening.
Good evening to you. Hello.
Yeah, our first lady, good evening. Karibu sana.
Okay, ningetaka kuongea na daktari.
Go ahead.
Okay, nilikuwa nauliza. Nishawahi kuwa na kesi ya msichana wangu. Msichana wangu akapata mimba. Alafu alipopata mimba ikawa kukaribia kupata mtoto. Hello.
Yes,
hello. Kukaribia kupata mtoto akaanza kutapika damu.
Okay.
Na sasa kuanza kutapika damu, nikashindwa ni shida gani alikuwa nayo juu mtoto hadi alikufia kwa tumbo. Baada ya hiyo tena akajaribu mara 2 kupata mimba, inatoka like about 3 months inatoka.
Wow.
Sasa nilikuwa na shida, hiyo ni shida gani na inaweza rudi tena?
Umesema kwanza alitoka na miezi ngapi?
Ilikuwa miezi pale kama karibu kupata mtoto, akiwa miezi 9 tu ikibaki dakika chache. Alianza kutapika damu. Kutapika damu kabisa, na alipoenda kwa hospitali alikuwa anaambiwa tu bado yako sawa.
Na mtoto alizaa?
Mtoto alikufia kwa tumbo.
Alikufia kwa tumbo.
Halafu baada ya miezi kadhaa akajaribu tena ikatoka, tena akakaa akajaribu tena ikatoka. Sasa nilikuwa na shida, si pengine ilikuwa shida gani na inaweza rudi pengine.
Okay,
thank you.
Okay. Ya kwanza inaonekana iko tofauti na hizi zingine.
Okay.
Yeah, because ya kwanza ni mtoto alikuwa hata ameshafika full term. Na kutapika inaweza kuwa ni ile tu anatapikaga ama ile kuexert contractions ikikuja, wakati mwingine mtu upasuka kwa esophagus, kwa ile pipe ya chakula.
Wow.
So hiyo inaweza kuwa haikuwa related. Hizi zingine ni miscarriages zinatoka 3 months, na hiyo ingine sikusikia amesema imetoka kwa 3 months also. So hizo mbili zinatakiwa ziangaliwe. Kuna test kadhaa zinafanyagwa, kuna hormone test, kuna zingine viral test, na pia ni vizuri kuangalia hiyo cervix.
Okay.
Akifikisha around 11 weeks, before afikishe miezi 3, angalia hiyo cervix. Pengine hiyo cervix ilikuwa weak.
Okay.
Yeah, na kwa hivyo anaweza hitaji stitching.
McDonald from Nairobi. Good evening.
Yes, good evening, Ndai.
Yes, fine, thank you, sir. What is your question?
Yeah, my question goes to the doctor.
Yes.
On two things. One is if someone has had a cut, maybe a surgery before, a reason there was an issue with appendix before, and then he had a cut. He had a cut to remediate the same. Would that one mean that if such a person would want to do delivery, has to do
Cesarean.
That's one. And two, is when somebody had done family planning before, that is the what's the name of that thing? Implanon, right?
Yes.
Implanon.
And it is over 3 years. It's over 3 years late since maturity.
Yes.
Is that an issue now that it's not being taken, and having visited doctors is unable to locate the same? Thank you.
Okay, thank you for that question. Doctor, will you pause and take both questions? There's another one coming in, and then you'll answer both together. Good evening. Thank you for calling Health Check.
Nimerudi tena, kweli ilikuwa imeisha.
Pole.
Sasa niko na swali. Mimi mwenyewe niko na shida. Na hii shida niko nayo, nasikia saa zingine kichwa inaniuma, alafu saa zingine unapata na kuanga tu na kizunguzungu, alafu ni kama nataka nianguke chini. Alafu tena shida ya pili, unapata kama nimeenda kwa haja kidogo, unapata na kojoa ile yellow. Alafu shida tena iko kwa tumbo, unapata shida tumbo saa zingine inafura. Saa zingine sijakula lakini nasikia tu imejaa tu.
Bloating.
Sasa hiyo ndio shida yenye niko nayo. So nataka daktari anisaidie.
Okay.
Na hiyo shida ya kizunguzungu.
Okay. Has that affected the birth? Okay, sawa. Asante sana. Okay. So you can take them both.
Yes, thank you. The first caller had asked about a pedicectomy.
Yes.
Whether you need cesarean section. There's no relation.
Okay.
What you worry is any cut on the uterus.
Okay.
Is what has a bearing on whether cesarean section or normal. Otherwise, a pedicectomy is on the skin. It's on the wall of the abdomen.
Okay.
You worry about a cut on the uterus.
Okay.
As to his second question about Implanon,
yes.
It is beyond 3 years. First and foremost, Implanon 3 years is expired. It is not guaranteed the care. I'm not too sure that he mentioned the rod is missing.
Yes, you can't trace it.
Yes, if it cannot be traced, you need to do an ultrasound.
Okay.
Yes, and if it is located, then that one might need to go for a minor operation to do some bit of dissection, and it will be found.
Okay.
For my friend Otieno, okay, headaches, dizziness, bloating, that needs a checkup.
Okay.
He needs to go in for a checkup. It can be maybe the blood is low. He said the urine is yellow, maybe he's not taking enough water. He needs to check his liver, he needs to check his kidney. So for Otieno, he needs to go and see the doctor for a more complete check.
Okay, we're coming to post-care. I don't know what the word is. What is it called? Postnatal? Postpartum. Yes, we are getting to that. Yeah. But we have Omar in Nairobi. Good evening.
Good evening too.
Thank you for tuning in. What's your question?
Yeah. My question is that I had my wife. she had a problem when she received antibiotics. Usually bleed throughout. So I don't know how would you help her.
Sorry, I did not get that question. Could you just repeat it one more time?
I'm saying that I have my wife. She has a problem about when she received the monthly period.
Okay.
She usually bleed throughout, like 1 month.
Wow.
Yeah.
Okay.
So I don't know what the problem is. I would like you to assist me about that question.
Okay, we've received the question. Let's pick our final question of the evening from Elizabeth in Makueni, and then we'll answer them all as we go to. Elizabeth, good evening.
Good evening to you.
Thank you for watching Hope TV. What is your question?
Okay, I was asking.
Yes.
The question to the doctor. Are there ways they can assess whether a person is going to deliver normally or as yes? And the other question, maybe you're pregnant, and then you find yourself that you have an ovarian cyst when you go to the radiography department.
Did you get that?
No, you said.
Can you repeat that?
Ovarian cyst?
After you've gone to the ultrasound,
yes,
you find yourself having an ovarian cyst.
Okay.
Is there a problem associated with the pregnancy, or maybe the doctor can answer that? Yeah.
Okay. Did you guys get that?
Yes.
Thank you so much, Elizabeth. I've been told the last one, kabisa. Okay. Mary in Nairobi. Mary.
Yes.
Good evening.
Good evening to you. How are you?
Fine, thank you, dear. We're wrapping up with you. What's your question?
So I had a CS my first pregnancy. It was an emergency CS. And now my second pregnancy, which I'm 3 months pregnant now, I've been told that I can't wait for 40 weeks. It's not advisable to wait for 40 weeks, but I don't understand. So can you please help me understand who that? Thank you.
What did you say?
Thank you. Sorry, Mary?
Yes.
Just repeat that last part of the question.
Sorry?
Repeat the last part of the question. You went through a CS, an emergency CS, and this time you're pregnant, you're 3 months, and what is the question?
Yeah, the same round, I've been told I will have a CS as well, but I can't wait for up to 40 weeks.
Okay.
So I don't understand. Yeah, I don't understand why I can't wait for 40 weeks. I've been told that maybe I can have a CS at 8 or 9 weeks. So I don't understand. So my question is, can you please help me understand why I can't wait for up to 40 weeks?
Okay.
What was the reason for your first cesarean section?
Calcification of the placenta.
The?
Calcification of the placenta.
Calcification of the placenta.
Yeah.
Okay.
Thank you so much. We're going to answer you right now. Thank you so much for watching. Dr.
Yes.
Let's go through all these questions.
Yes.
Thank you so much for the questions.
There was also Mal, the wife has prolonged periods.
Yes.
Yeah, they come. That needs to be checked because sometimes it's not period. Sometimes maybe there is an issue like the cervix.
Okay.
So we'd like to know, have they done the pap smear? So they need to do pap smear. They can be polyps, either cervical polyps, endometrial polyps, so they need to do an ultrasound before you can jump to hormonal.
Okay.
Yeah, so you need to have those checkups, a scan, pap smear, and then finally the hormones.
Okay.
Elizabeth had 2 questions.
Yes.
And I think the first question was, what was it? I'm forgetting.
Was it ovarian cyst?
Yeah. One was ovarian cyst, and,
yes.
the other question was, oh gosh, I'll remember.
Yes. So the ovarian cyst. She talked about ovarian cyst, and the issue about the ovarian cyst is not a problem. Yeah, they should be able to deliver normally with no issues. However, if the ovarian cyst is big, then it means sometimes it can coil, what we call torsion, and become very, very painful. And they can be operated even when they are pregnant.
Okay.
Sometimes it can just rupture and pour the fluid, and then becomes very, very painful and also bleed.
Okay.
But most of the cysts, yes, will be normal. and especially if it's in the first, second trimester, and it's a small cyst, that is where the pregnancy is getting its hormonal support from. And that cyst should not be interfered with. It's called a corpus luteum cyst. Yes.
Okay.
The other question was about the cesarean section. If a decision has been made to do an elective cesarean section, then normally we do at 39 weeks.
Okay.
When we are happy the baby is grown.
So it's because of the timing, not necessarily anything to do with...
Yes, it's the timing, 39 weeks.
Okay.
If they go into labor, then you can do an emergency, but you give 39 weeks. The reason I asked about the previous reason for cesarean section, because these days, if you're in a good setup, where you have skilled labor force, you have a surgeon nearby, theater nearby, then there's room to do what is called TULAC, trial of labor after cesarean section. If the reason for the previous cesarean section is not repetitive, for example, if the reason for cesarean section was the small pelvis, then it means that they'll never be able to deliver normally because they always have a small pelvis. Like the caller, I think Mary, the cesarean section was the placenta. If the placenta is not there now, and the baby is good size, the pelvis can accommodate that baby, then they can be allowed under some guidelines to try to have normal, even on the advent of a cesarean section.
Elizabeth had asked if there is a way to know if somebody will give birth.
Do normal or cesarean?
Yes.
Yes, good question. Our aim all the time as a team is to have normal delivery, and that should be our aim. The commonest cesarean sections occur as emergency cesarean sections, intrapartum, during labor. You know, something goes wrong, bleeding, the baby's fetal heart, prolonged labor. Yeah, those are some of the commonest. And that's when you have a cesarean section. The rest are known if it's an elective for some reason, but you always aim to have a normal delivery, and you always encourage the mothers to try and internalize it and think psychologically that they want to have a normal delivery, so that they can have the energy, the psyche to even try, even as they are assisted by Esther and her team. Then they can have normal delivery. So sometimes it's not easy to tell whether you'll have normal or cesarean section, unless other things come. Maybe there's a big baby, or we tell you the pelvis is small, or the position like breech. Those ones you already know that you like it to have a cesarean section. But if you're having a normal antenatal follow-up, the baby is okay, everything is okay, it's very hard to know whether you'll have normal cesarean section. But all times you have to be ready for a cesarean section as an emergency.
We are going to postpartum, and we have our guest in studio. What's the name of our guest?
Michael.
Michael, hi Michael. So before we talk to Michael, question, and you can answer this, our doula in studio. What leads to no labor pains up to 42 weeks in pregnancy, leading to the baby even dying in the womb?
So sometimes it's the position of the baby, so that the baby is not well engaged. So usually when the baby engages, it's a process, as Dr. said.
Yes.
Places some pressure on the cervix, and that sends signals to the brain to produce hormones that will help you go into labor.
Yes.
We encourage moms, if you've reached your due date, most of us know our due date. It is an estimate, but if you've reached your due date and you've gone a few days, 2, 3, 4 days, and the labor pains have not come, it's important to go for clinic.
Yes.
Because usually those last two, if the baby delays too long, sometimes the placenta can age or calcify, so it's not giving nutrients to the baby. There could be another reason why this baby is not coming. It is very, very important, and those are good reasons to get an induction. And the doctor will gauge and decide after an examination. So please, if you've reached your due date, you can give yourself 2, 3, 4 days, and then go to hospital.
Okay.
Yes.
Let's talk about Michael. Michael is out of the hospital. Dr. said, good job. Wow, very nice. You can now go home.
Yes.
What do we need to learn to do with Michael?
Okay, so the first thing, right when you're still in hospital, it's very important to make sure that you know how to breastfeed, especially if that's how you're planning to breastfeed your baby. Please learn in hospital. And usually we encourage moms to put the baby on the breast within the first hour of life if it is a normal delivery.
Doctor, is that what you do?
Yes.
Okay.
Yes. And if it's a cesarean section, within at least 2 to 3 hours, because you'd have finished theater and come back.
Okay.
having a cesarean section does not mean that you cannot still put your baby on the breast. Your healthcare providers will be able to assist you to put the baby on the breast.
Okay.
So when babies are born, usually if you've watched a baby being born, they'll cry, and we're happy when they cry, and their lungs fill with air. And then the next thing they do is, what are they looking for? They're looking for the breast. In response to that, mother's breasts actually, when the baby starts to cry and those hormones start to change, mother's breasts actually emit a smell that smells exactly like amniotic fluid.
Wow.
And so what happens when you bring your baby close to your breast, they smell that smell.
Something that they're used to.
They're used to. That's what they were smelling. And that triggers their suckling reflex. And so you'll find them opening their mouth. And what we want to do is to put the baby immediately to the breast, because that is the best time to stimulate this suckling reflex. And when you put the baby on the breast, it also now talks to your brain. It tells the brain, now the person who was inside has come out.
Yes.
We need to make food for that person. So breastfeeding is successful when there is communication between the baby, the breast, and mommy's brain.
Okay.
And so this is the customer.
Okay.
The customer comes to the breast and places an order by suckling. When they place an order, that goes to the brain and tells the brain, which is the factory, let's make milk.
Okay.
So it's a circuit. So that's why we are putting the baby often to the breast. Now, it's very important for moms to know this. At birth, the exact size of a baby's tummy is this. Can you see that? It's really small.
Okay.
It takes approximately the size of a grape.
Okay.
It takes approximately 5 to 7 ml of milk.
Okay.
And so what happens is this baby, you don't need a lot of milk. You know, most people touch their breast and say there's no milk.
There's no milk.
You just need to put the baby on the breast often.
Okay.
And because the stomach is this small, of course the baby will be hungry quickly.
Yes.
In an hour or 2 hours, they'll want to
Again.
come back because the stomach is very small.
Okay.
So it's usually important for moms to know the baby will be born with a tiny tummy. Then they will poop black poop that looks like this. Yeah, and it's called meconium. It's all the fluids they've been swallowing, but they don't poop in the tummy. Daktari does not want them to poop in the tummy. We want them to poop when they are born.
Okay.
So they will poop that black poop that is stimulated by suckling, by the milk the mommy makes.
Okay.
And it's usually dark and sticky. By day 3, guess what? Baby's tummy has
bigger.
grown.
Wow.
It has grown because now
Wow.
baby is starting to make to take in more milk.
Yes.
And it expands the baby's tummy.
Absolutely.
And the poop changes to that color. And by day 5, it's bigger.
Wow.
Yeah.
And the poop changes to that color.
that color.
Okay.
Yellow. So it's important for moms to know that. So
Okay.
these are some of the things that we teach them at home so that they know what is normal. Because if it's 2 weeks and your baby is still pooping black poop, then we are worried.
Okay.
We want them to transition that poop quickly.
Okay.
We also teach them on how do you know that your baby is actually getting enough milk so that your baby does not get dehydrated. Because if they get dehydrated, the baby can get kidney failure and
That's
other
true.
issues.
Esther, the doula, I don't want you to give all the information because I want people to look for you. I want them to find you and to interact with you. So that's what you learn and much, much more. And Daktari as well, he's here to walk with you through the journey. What an exciting episode. I want to give you literally half a second to give your final remarks as we wrap this one up because we have news at 9 p.m. with Tony Omondi and it's almost there. So go ahead, just give your finals with Michael and that sample
The
of...
boob.
Yes, the boob.
Okay, so it is every mom is equipped with an inner wisdom. I keep saying that, an inner wisdom to nurture and care for your child. But you still need the information.
Yes.
So equip yourself with information. Together with that inner wisdom, you'll be an amazing mom.
Wow.
Yeah.
Every mom, inner wisdom.
Yes.
Daktari, as we wrap up this season, what would you advise?
Antenatal care, very, very important.
Okay.
And start as early as possible in the first trimester. Some moms come quite late. You can miss many things. You starting early means that you can be able to get some problems and fix them early, rather than coming late. And then it will be hard, to be longer, damage is already done. So we encourage, because I've found many moms come quite late, especially the ones who have delivered before. They say, there's nothing that's happening, me, I'm a professional, I know these things, so they come quite late. And you do sugar, maybe there's a problem. Probably you do HIV, maybe there's an issue.
That's
so,
true.
Yeah, so we would encourage all the moms to start antenatal care in the first trimester.
Okay, thank you so much, and thank you for watching Health Check. We're here to make sure you're informed. Our professionals in all the sections are here today. Dr. Wachira Murage, obstetrician-gynaecologist. Check him out at Savannah Center.
Yes.
Yes, and of course, Esther, who is a doula and childcare specialist. Esther the doula, Google her. She's famous. It's the famous. Thank you so much for watching. We'll leave you with the first aid clip. Keep it right here, Hope TV, where you look and live. The video is going to be up on YouTube, so share it. Share the Facebook link as well. Let's get everybody informed. Up to next week. See you then. You get your repeat episodes right here on Hope TV, so don't touch that dial. Until next time, thank you so much.
Thank you for having us.
And thank you for calling and texting and hang out with us. God bless you.
In this segment, we're going to talk about a casualty who is choking. When you look at your casualty, you will notice that she is coughing. She's also having a difficult time breathing and speaking. She also tries to get your attention, and she's grasping at her neck. So once you notice that, what you're going to do, you're going to encourage the casualty to continue coughing. Can you cough? Try and cough. Cough. Is it better? No. When you notice that it is not better, what you're going to do, you're going to stand behind your casualty, take your arm, support the abdomen, and then you're going to lean your casualty forward until the chin is below the chest. And then you're going to give 5 back blows, up to 5 back blows between the shoulder blades. 1, 2, 3, 4, 5. Once you do that, you check whether the casualty is still choking. So if my casualty is still choking, I can try something else. We can try abdominal thrusts. So I'm still going to stand behind my casualty and then place one foot between their legs. And then I'm going to locate the navel, and just above the navel, I'm going to make a fist and put it above the navel. And then I'm going to support that fist, and then I'm going to give up to 5 abdominal thrusts, which are going to go in, up, in one movement. So 1, 2, 3, 4, 5. Then you check whether your casualty is still choking. So if you find that the obstruction has cleared, you can try and assist her to sit and just reassure your casualty. And once she's relaxed, that's when now probably you can get her a glass of water to calm her down. But do not give her anything to eat or drink while she is still choking.